Yes.
You can skip the first slide. You can go to the second one.
Yes. So Lisfranc injury is named after York Lisfranc de Saint Martin, which is the injury of the tarsometatarsal joint of the foot. Wide variety of injury from the low energy ligamentous injury to high energy fracture dislocation would be sometime open. Low energy injuries are often misdiagnosed as sprain, and that is the problem, and treated inadequately, whereas errors in fixation of high energy injuries entail avoidable complications. A little about anatomy. We know that the Lisfranc joint is formed by the five metatarsal articulating with the three cuneiform and the cuboid bone. These structured together form the transverse arch of the foot, which are akin to no Roman arch, and the second tarsometatarsal complex acts as a keystone. And the Lisfranc ligament, which is the intraosseous ligament between the first cuneiform and the second metatarsal base, acts as a very important stabilizer. So we need to have reconstructed this bony ligamentous structure well in all our patients. Right, can you see my next slide?
Yes, go ahead.
Right. So in diagnosing, the most important thing is history initially, because we have to see all the cases with high index of suspicion, especially the low energy injuries. So any case of road traffic accident, sports injury, where there's axial lowering of a hyperplantar flex foot, and there are symptoms of pain, swelling of foot, and difficulty in walking, we have to examine very carefully, as well as the open crush injury of the foot. And if there is crush injury and there is no open wound, the chance of compartment syndrome is very high. So you have to keep an eye open for that as well. On clinical examination, there would be swelling of the midfoot as well as the midfoot forefoot junction. There will be telltale plantar ecchymosis, which you can see in the picture. Upon palpation, there will be tenderness at the tarsometatarsal articulation. And we can do the piano key test, in which we stabilize the hindfoot and midfoot and try to move the metatarsal base up and down, much like the piano key. And if there is abnormal mobility, we must suspect this injury. There would also be increased gap between hallux and the second rib, which we call positive gap. That would be there in clinical examination. There would also be altered sensitivity in the first vertebral space because of the involvement of the terminal medial branch of the deep peroneal nerve, which supplies the first vertebral space. The ability to discriminate the 2 point will be gone. So we have to do all this clinical examination. And in our inspection, even a small, very subtle plantar ecchymosis is not to be missed. Diagnosis, the first thing is X-ray. We do the standard foot series, AP, lateral oblique views, stress views, weight bearing views. The X-ray changes could be subtle as well as very obvious, as Dr. Girish has already shown. And these are the radiological parameters. The first 5 points are there in the normal X-ray. In any deviation, we must suspect this injury, as well as if there is flex sign, which is nothing but a sliver of the bone, which is present in the first intermetatarsal space. This could be because of the avulsion injury. So we have to look for this flex sign. Lateral view as well, we know that all these lines are normal in lateral view. If there is some deviation, as shown on the right side, we have to suspect this injury. CT scan, yes, CT scan helps us in planning, especially when there are comminuted fracture of the base of the first or second metatarsal, or maybe cuboid, or maybe the cuneiform. So CT has a place, both 2D and 3D. MRI, especially in those neglected cases are not very clear and obvious bone injuries are there. So MRI can really diagnose any kind of ligamentous injury. Coming to the treatment, there are certain concepts that we need to familiarize ourselves with, the 3-column concept, and also the classification. We understand classification has to be able to devise the treatment plan properly. The 3-column concept, the medial column as well as the middle column, they are very stable, and any injury there needs to be fixed in a very rigid fashion. K-wires will not do here. We have to use screws or plate, as I will discuss later in my talk. The lateral column, which is the 4th and the 5th ray, they are the most mobile structures in the foot, and then they should be that ways only for balancing our foot on especially on an uneven surface. So if the fracture is there, any kind of instability is there, we have to use K-wires, which are to be removed after 6 weeks. These are classification system, Hardcastle-Myerson classification, also Myerson modification, where he has further subdivided into D type, D1, D2. If the distance is less than 2 millimeter between the first cuneiform and the second metatarsal, maybe we do not do any kind of surgery. But if it is more than 2 millimeter, then surgery is required. If it is purely ligamentous type, then probably primary arthrodesis. If bony structure there, then osteosynthesis is the choice of treatment. Also, for purely ligamentous injuries, this Nunley Vertillo classification, which was given in 2002, tells us about the different type of soft tissue injuries, different grades, grade 1, 2, and 3 of the Lisfranc ligament injury. So the treatment, the goal of treatment are to restore the anatomy of the forefoot and midfoot, and hence its function, preventing any later arthritis and disability. Non-operative treatment has very, very, very limited role, as significantly lower functional and radiographic outcomes noted with non-operative treatment. These probably are four types of candidates where non-operative treatment is okay, when the injury is stable or if the patients are not fit for surgery. In the settings of serious vascular diseases or severe peripheral neuropathies, patients like severe Buerger's disease, severe uncontrolled long-standing diabetes mellitus, or some such. This is the most important slide here as far as treatment is concerned. This is the treatment algorithm in which we broadly divide all the injuries in two parts. One is a stable type and one is an unstable type. And if the stable type is there, we do our assessment by clinical examination as well as radiological examination. If they are indeed stable, we may go for only these very limited number of patients with non-surgical treatment plan. Otherwise, if it indeed appears to be stable, turns out to be unstable, then we have to do the surgery. If it is purely ligamentous, then arthrodesis. If it is bone injury, then open reduction, internal fixation. And for those fractures which were unstable to begin with, there were very frank dislocation. If there is high energy, a lot of soft tissue issues are there, then initially we can do some kind of close reduction and temporary fixation with K-wires and external fixator. Fasciotomy, if required, is to be done. And once the soft tissue settles down, then we need to go ahead with the surgery. Right. So what is the goal of the treatment? It is to achieve stable anatomical reduction. See, in the longer run, it is the quality of perfect anatomical reduction and the quality of fixation, which will really, really show us what is the long-term result is. So in those cases, I'll discuss the different 3-4 options of surgery. First is temporary pinning and delayed open reduction and internal fixation cases where there is significant soft tissue swelling. Axial alignment helps us in allowing better healing of soft tissue. So such cases, they need to be, fixed with K-wires or X-fix. And this also cuts down the risk.
2 more minutes, Shant.
So definitive surgical intervention is done once the wrinkle sign appears. And when the patient is fit for surgery, we do rigid internal fixation, the first, second, third tarsometatarsal joint, K-wire fixation, fourth and fifth joint, as I've already said. Reduction is always done from medial to lateral. Single incision versus double incision, we'll see how screw versus plate is to be decided. Right. And primary arthrodesis is done in cases where the injury is purely ligamentous, or if the treatment is delayed, or if there is chronic deformity. In such cases, we have to go ahead with arthrodesis. Certain surgical controversies, osteosynthesis versus primary arthrodesis. Osteosynthesis works better for bony lesion, whereas primary arthrodesis has better outcome in purely or predominantly ligamentous lesion. What to use, screws or dorsal bridge plating if orifice to be done. See, it is seen that screws cause articular cartilage damage. So many workers are shifting to dorsal plating with the screws that do not violate joint. But plate does require wider surgical exposure and therefore can increase soft tissue irritation. Therefore, the rational approach would be to use plate for comminuted fracture of cuneiform and or metatarsal base. Right. Single versus dual incision. The classical approach is always the dual incision, the middle one over the first intermetatarsal space, and the second one over the fourth metatarsal. But sometimes the narrow skin bridge and really cause soft tissue issues. Hence, some workers advocate single large incision. There are certain surgical cases, the 3-column fracture, where the medial and the middle column has been fixed rigidly and the lateral column has been fixed with K-wires. Here there was associated injury of the cuboid bone, which has been fixed, just to show that associated injuries are to be taken care as well. Sometimes screw direction is from base, or this is the latest one, from the base of second metatarsal to the cuneiform, because the cuneiform, the medial cuneiform gives you a good bone stock for screw hole. Complication: post-traumatic arthritis, non-union, malunion, deep infection, and plantar valgus foot deformity. And you need to do arthrodesis in such cases. The take-home message is the timely and correct diagnosis of all the cases. These are of paramount importance. Devise correct treatment strategy suitable for that injury type. If we are attempting osteosynthesis, anatomical reduction, and correct metafixation is the key. If attempting arthrodesis, we have to ensure union at the arthrodesis site, communicate well with the patient, make him aware of all the potential complications. Thank you so much, sir.